Hey, good morning, good afternoon, good evening, wherever you may be. We want to welcome you to this Data for Nutrition webinar about using the LiST tool for estimating impact of nutrition programs. Next slide. Before we get started, just want to cover a few logistics. So the microphones are muted during the presentations, and we ask that you use the chat box at the bottom of your screen to chat with other participants, or if you're having any trouble, please use that chat box to contact our coordinator, Riley. We'll answer as many questions as we can during the Q&A. So please go ahead and put those questions in the Q&A using the Q&A function. And please include your name of the speaker, well, to you're addressing the question, but in this case, we have one primary speaker. Answers to all the questions will be shared a week after the webinar, and a recording of today's webinar will be immediately available on the Data for Nutrition YouTube channel. So if you're experiencing any technical difficulties, we ask that you exit the webinar and open a new browser, re-enter the webinar link, and then run an audio setup wizard. Or if you're having trouble, you can also reach out to Riley by selecting all panelists in the chat box. Okay. So just want to remind you that we, as the Data for Nutrition community of practice, aim to provide members with opportunities to share knowledge, experience, and questions relevant to strengthening nutrition data value chains. And we do welcome all members, if you're interested, the opportunity to present webinars or other ways to share your own work or your own findings through our platform. And as of today, we have 825 members and continue to be growing. I'm your moderator today. My name is Rebecca Heitkamp, and I'm an associate scientist at the Johns Hopkins Bloomberg School of Public Health and lead the Data Dent Initiative. Our speaker today is Neff Walker, who is a senior scientist at the Johns Hopkins Bloomberg School of Public Health. He's been on the faculty of the Bloomberg School since 2007, and before that, he spent about a decade working for UNAIDS and UNICEF. And his primary focus throughout his career has been developing models that can aid program planning, of which the LiST tool is the one we're going to focus on today. So I'm going to hand it over to you, Neff.
Okay, I think I did the mute button, so I should be okay. Good morning, everybody. Also, you'll see that Hannah Tong and Yvonne Tam are both here. They both work. We all work together on the LiST tool as a big part of our work, and they're both available for the help with questions and things. But today, what I'm gonna try to do is take my 30 minutes or so and spend about half of that walking through so you understand the approach to the model, kind of the theoretical backing and how it's structured. And then the next 15 minutes giving you examples of basically opening up our new web-based version of the software, LiST Online, and walking you through how you could use it to answer questions that might be relevant to nutrition programming. So please feel free to ask questions as we go along. And I know Rebecca is going to be checking. So if there's something you don't understand and you want me to not wait till the end to get to it, but she'll interrupt me, and feel free to do that. It'll be no problem. So I'm gonna share my screen now, see if I can pull this off. It always offers these options, and let's see if this works. Somebody can turn their mute button off and say, yes, I see the screen. That would help.
We see your screen. It looks great.
Okay, so the idea is how LiST works and where it came from. So LiST kind of grew out of about, what's 18 years now. There was a big child survival series in Lancet in 2003 where they were trying to, I think, work on refocusing on child survival as an important kind of global goal. And one of the things they did in that work is they tried to create a fairly simple model that looked at, given the current interventions we have, if we scale those up, could we reach the MDG targets? And so They developed a model that I believe had 40 interventions. There were interventions that could be delivered at community level, things like ITNs or antibiotics for pneumonia, and then tried to develop a model to link those interventions with their efficacy, how effective are they in reducing cause-specific mortality. So it was a fairly simple, straightforward model. And I think they ended up saying, well, 60% of the mortality could be reduced by the current set of interventions. So trying to make the argument we didn't need to wait till something new came along to address under 5 mortality. In fact, the interventions we had were good enough if we could just take them to scale. And from that, what's happened is I actually was involved that group, but in the costing end of it. And then later we took that same model and tried to expand it and took the same general approach. So what you see here, this is from the LiveSafe tool website. It's called the LiST visualizer that kind of gives you a general overview of how the model works in terms of what's in the model. But I want to back up just a second before I go through this. The idea is LiST in some ways is really a demographic model. That for any country, what we do is we start with the demography, a full demographic projection that looks at births and deaths and mortality rates and things like that. And then we make the assumption that changes in mortality for under 5 mortality and also maternal mortality is going to be driven by changes in interventions, so that there's not secular trends, though we know if we look over time, mortality has gone down in countries, but the LiveSafe tool takes the approach that the changes in mortality are going to be driven by interventions. So that, in other words, as women have access to better childbirth care, the number of maternal deaths and neonatal deaths will go down. So that's kind of the model is set up that way that says, yes, what we do is we start with a baseline and that describes what it's like in a country in terms of current coverage of interventions, cause of death structure, mortality rates. And then we say how that's going to change is by increasing coverage of interventions, that those interventions are efficacious and they will reduce either cause of mortality or they'll reduce risk factors. So just so you'll know, that's kind of the main thing. And then obviously nutrition plays a big role in terms of risk factors. And so let me try to walk you through this. Now, the LiST visualizer, what it shows, as you can see on the left of the screen, these are categories of interventions. It's kind of that occur during different periods, like pregnancy or childbirth or periconceptual, prevention, vaccines. You can see that, let me make this a little bigger, and that for each of those, they have their specific interventions. So if you click on, let's say, pregnancy, what happens during pregnancy? It now opens up and shows you, we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 or 11 interventions that occur during antenatal care that should occur during pregnancy. So the idea is that each of these interventions is linked to specific causes of death or risk factors. Let me reset this. And the same thing holds. So let's go down here and we could look at preventive interventions. And then here's a list of interventions that are in the model. And not most are health sector, but there's a few things that are washed, like piped water or hand washing, basic sanitation. So there's some things that are broader than healthcare interventions, but fairly strongly linked. And then for each of these interventions, they are linked to either a cause of death or a risk factor. So let me take an example. I'm going to call isolate vitamin A supplementation. So how does vitamin A supplementation have an effect on child or maternal health? Well, you can see 2 pathways. That one pathway, vitamin A supplementation, has an impact on diarrhea incidence. Diarrhea incidence then in turn has an impact on stunting. And then stunting is a risk factor for different causes of child mortality: diarrhea, pneumonia, meningitis, and measles. So children who are stunted have higher relative risk of dying of those things. Vitamin A supplementation also has a direct link to diarrhea mortality. Also, if you want to play with the visualizer, you can click on it, and it shows the efficacy and the source of that efficacy value that we use in the model. So here's a review from 2011. It's basically saying you'd reduce roughly half of diarrhea mortality with, or half the risk of diarrhea mortality with vitamin A. So the idea is that the model builds these structures that connect, let me just reset one more time, that connect interventions to risk factors, and then the risk factors to mortality. So the idea is, again, going back to this idea of a demographic engine. The way LiST works is it simply says, as you scale up these interventions, it's going to alter both the risk factor and also mortality, both directly and through the reduction of the risk factor. Just so I can do a little more that's maybe, I'm going to look at, here I clicked on breastfeeding, and I'm going to isolate how we handle breastfeeding in the model. So really for us, breastfeeding, the intervention is breastfeeding promotion. And you can vary different levels of promotion, but breastfeeding promotion has an impact on early initiation of breastfeeding, which then has an impact on neonatal sepsis, neonatal pneumonia, and neonatal diarrhea, those causes of death. It also, breastfeeding has an effect on exclusive and continued breastfeeding, which then has effects in our model on kind of post-neonatal mortality, as well as it has an impact on diarrhea incidence and on stunting, which then again, as we talked about before, stunting is a risk factor for basically infectious diseases. So that it's going to have some direct impact on changing behavior in terms of early initiation and exclusive and continued breastfeeding. Those are going to have a result in change in mortality, cause-specific mortality. It has this indirect effect through diarrhea incidence to stunting, and then finally back to mortality. So the idea is that for each country to be able to run the model, what we have to do is we have to describe the country in terms of, we talk about it baseline, whichever year you're using, in terms of interventions, what are the current coverage of those interventions, and then risk factors, what's the current level of risk within that country. And that includes stunting and wasting, birth outcomes, fertility risk, and then also what's the current cause of death structure. So what are the causes of death? And what are the rates of mortality? This is for kids and mothers as well as stillbirths, but really I'm going to be talking about mortality most of the time. So the idea is that when you run a model, what you're going to do is you're kind of accepting our general structure. We're going to load in the information about intervention coverage, levels of risk factors, and cause of death for the year you want to model. You can use LiST for current, but you can also, we have data back to the year 2000, so you could go back and run a historic analysis to see what's driven the reduction in mortality, how that's related to changes in coverage of interventions. But the idea is that that's kind of how the model works, and as you scale up these interventions, it will have an impact on mortality. A couple of quick things. You also have within LiST is embedded in a larger piece of demographic software that includes information I have right here called FamPlan module. Basically, that is a fairly, I think, simple model, but works well on family planning. So it allows you to scale up contraceptive prevalence rate. It allows you to manipulate method mixes and what impact that has on pregnancies and births. And that also reduces fertility risk, which strangely enough, I don't know if we want to call it a nutrition sensitive intervention, but scaling up family planning can have an impact on birth outcomes, which then would have an impact both on stunting, if you can see the link that comes down here to stunting, and also a direct impact on causes of death of neonatal mortality. So that you can, while the model is fairly simple in its general conception, as you can see, the interconnections can get fairly complicated. I'll do a quick one to show you again, since this is a nutrition. I'm gonna isolate. This is what we have in the model that is related to stunting. So what I've done is I said, isolate all the links within the model that relate to stunting. So you can see stunting has some, like here, it has an impact on mortality due to diarrhea, due to pneumonia, due to measles, meningitis. But please note how different things have fairly complex relationships. So for example, family planning has an impact on birth order and birth intervals. Let's look at this on birth intervals. So if you promote the right kind of family planning, you can increase the birth intervals between births. Well, we do know that short birth interval is a risk for being born. Let me go look here, small for gestational age. Small for gestational age is also then linked to stunting. So the idea is that even family planning could have a small but significant impact on stunting, which would in turn have an impact on cause-specific mortality. So it's a lot to cover, but I just wanted to kind of highlight some of the things to you again. And if we look at kangaroo mother care, again, it has some specifics that it has an impact on exclusive and continued breastfeeding, that women who get KMC are more likely to breastfeed and breastfeed exclusively. And it also has a direct impact on neonatal mortality due to prematurity. So KMC will have a small impact on nutrition, but there will be, and it'll also have a bigger impact on neonatal mortality due to prematurity. So let me pause for just a second here and see if there are things you would like me. Rebecca, are there any questions at this point before I?
No questions so far, but again, encourage folks to go ahead and add those as we go if you have questions along the way. And Neff, I'll bring them back around to you if we get any.
Okay, I'm checking my clock. Okay, so that's kind of a general overview of what happens. I think just quickly, let me review that, we talk about, so in terms of nutrition outcomes, we're really, if I go back to my reset, that the outcomes that we have that are specific to nutrition are primarily in the risk factors: maternal anemia, birth outcomes, age-appropriate breastfeeding, how that changes over time, wasting, disease incidence is not really, that's kind of associated, but not a nutritional outcome, and then stunting. So that what happens is in our model, you're able to scale up interventions. Not only will it compute the mortality reduction, but it'll also compute the changes in wasting, stunting, birth outcomes, and maternal anemia. So when we do this, when you go in, the way you run a scenario is you go in and you change coverage of interventions. Let's say you increase coverage of interventions. Well, it's going to have an effect on stunting, wasting, all the risk factors, and those downstream will have an impact on mortality, but it's also going to produce you new estimates of your nutrition outcomes. So you could answer the question with LiST, okay, if I scale up, if I have increased the appropriate complementary feeding of children between 6 and 24 months, it will say what's the impact is that going to be on mortality, but also it will do that by changing stunting. So it'll allow you to estimate stunting. Same thing for other interventions like wasting, where you can see in wasting, we have Complementary feeding has an impact on it. Treatment of SAM and MAM have an impact on wasting, and then those downstream have an impact on mortality. So all of the things within the model are recomputed. So basically you can pull out not only the deaths averted or deaths averted by cause, but also the change in risk factors. So what I'm going to do now, if I can get back to this, is I'm going to open up our software. So LiST has been around now for about 13 years. And up until now, it's always been on a desktop version, and we still have a desktop version. But we also decided to do a web-based version, and that's what I'm going to be walking you through today, because some of you may have seen LiST on the desktop, but not LiST online. This we released in January. One of the reasons we wanted to do this is, one is we thought we'd give us an opportunity to have a better interface. And for those of you who've ever looked at LiST, this is a lot different. And the other thing it also allows us to do is that people, now that we have LiST running on a server, people can develop their own apps, their browser-based apps that then call and use LiST for computations. And so there's several, that's kind of what UNICEF does with Equus, a piece of software they have that they use LiST as the calculation engine. And then we've recently done one for WHO, created an app for looking at COVID-related disruptions in services. And then it allows you to enter information related to from your HMIS system about disruptions, and then LiST would compute the lives lost to them. So let me just walk you through. There's three main things. We're not really going to talk about missed opportunities, but what I'd like to do is show you both explore data and then how to do the projections, how to actually run a model. So let me see if I can click on the right button. So what happens is I go in and I say, well, I have to pick a country. It opens up and says, select a country. We have data for about 115 countries, low and middle income countries, where we try to reload the information. And let me just do, Bangladesh. People that know me always laugh about, well, I'm always using Bangladesh, but they do have lots of data. And so what happens is I've loaded in Bangladesh, and I can go and say, well, what kind of information I want to explore data. So a little bit like what DataDent does. And you could say, well, let's look at cause of death. And I say, well, I want to look at both neonatal and child. And it'll create just a quick display showing you for child, the 1 to 59 months. Here's the mortality rate over time. So we have the estimates from ICME from 1996 through 2019. And then we have the cause of death structure. So you can see that if we go back to the year 2000, diarrhea at that point was 22.85% of under 5 mortality. And by the year 2017, it's dropped to 16%. And that same period, under 5 mortality has dropped from 86 to 33. So Bangladesh is one of the countries that met the MDG targets. Other things you can look in the model, if we look at health and nutrition, it then opens up and says, what do you want to do? I'm going to show you a couple. Nutrition deficiencies. Let's look at status at birth, low BMI, and maybe stunting distribution. And you can see there's other things we have in there. If you wanted to look at poverty and food security, I could do that as well. And I create a display, and it just shows me what information do we have in Bangladesh. So if we look at poverty and food security, you'll see that basically we don't have yearly data, but we do have a few different estimates that percentage of 5 living less than $1.90 a day went from 34 to 25.7 in 2005 to 19.6, 14.8. So we try to put all the data for this whole period is available. Then you can look at stunting distributions of, again, we don't have yearly stunting distributions, but we have, whenever it's been collected over time, we have it by different age periods. that if you go back to stunting, you could say, well, I want to look at stunting in a different age group. Also, for any of these things, you could go and say, well, I would prefer, rather than having a graph, I want to download the information or change graphs or do a scatter plot. It allows you to do that. Here we look at status at birth. Really, there's only one estimate. These are kind of global estimates, but for each country, that says of all the births, roughly 11% were preterm AGA, and then there were preterm SGA, and then only just under half of all births were, we would say, not at-risk births. So that there's quite a bit of risky births within Bangladesh based on these estimates. And then here is some of these we use in our models and other we don't. These are estimates over time of nutritional deficiencies. For children, you can see we have about 17 here. Also, for any of these things in the model, you can go and copy or download and look at it. So that's kind of one of the things that's really different about LiST. Excuse me, let me back up. Is that LiST Online is that one of the things we wanted to do is we realized we had huge amounts of data available to people, but it wasn't readily accessible. Now in the model, it's fairly easy to open it up, pick a country, and see what data are available. The data come from different sources. Most of the coverage data is from DHS and mixed surveys, so nationally representative surveys, also a little bit from malaria indicator surveys. We don't have as many, usually we don't have smart surveys data in the model. You can add data yourself, but we don't track smart surveys because often they're not nationally representative and there's no easy public access. Other things like mortality rates and cause of death generally come from UN estimates of that. For the mortality rates come from the Interagency Group on Mortality Estimation at the UN. The cause of death structure comes from WHO. So we try to update that fairly regularly. It usually takes us about a year after surveys are run before they're entered into the model, because we have to have the data sets and then reanalyze to ensure we're doing consistent approaches. So let me quickly, since I don't have a lot of time, show you how the projections work. And so that what happens is when I've just switched over and now I want to run a projection. So what I'm going to do is just do a couple of quick examples. So one example is that I'm going to go up and so I'm going to do this right time. I'm going to just make a fake name. So the question is, in Benin, the government's trying to make a decision. I don't know if I'm sure all of you guys are keeping up with that a little bit, about should they be switching from providing iron to pregnant women to be supplying multiple micronutrient supplementation, which include iron, but also other micronutrients. So one of the things, if you're trying to make that decision, is, well, how big of an impact would it have? And so that's a perfect kind of question that LiST could answer. So I come in and I select Bangladesh, and I'm saying it automatically defaults my period to the current date, 21 to 2030. It says we have data from about 2018 is the most recent data. So we're fine with that. And say, okay, I want to run a test on that. Now I've set my thing up and I say, create projection. Now this is where we're now computing, we are communicating back with the server. So again, all of this is just in my browser at this point. So it's going to go back and it takes a little time. And again, it's one of the reasons we still have a desktop version, because you may be in situations where you have poor internet connectivity and it'll take too long. So now the key is, I said, I want to be able to answer this question about what if we switch from iron to multiple micronutrients. So I'm going to go here and I'm saying, okay, I want to manage interventions. And it says, okay, what interventions? Well, it allows you to do by outcomes, but for me, I don't know what the outcomes will be, but I'm going to go in pregnancy, this is what I want to do. Now in LiST, this is a little different, is that we have iron supplementation and multiple micronutrient kind of linked together because you're not going to do both. Other interventions, you can scale up all 75 interventions that are in the model at the same time, but you can't scale up both iron supplementation and multiple micronutrients supplementation in pregnancy because you're going to do one or the other because multiple micronutrients. So I'm going to do that and I say, okay, I want to do that, and I say apply. So you say, that's the question I'm going to do. Now it's going to say, well, once you've done that, it's going to say, what are you going to do about coverage? Well, what happens is that if you see in Benin that they're basically, their current level of coverage of iron supplementation in pregnancy is 47.1%. So I want to answer the question, what would happen if I got rid of that and did multiple micronutrients? So what I'm going to do is I'm going to scale up multiple micronutrients to the current level of iron supplementation. And I'm going to say, and I can duplicate this. And then I'm going to go back and I'm going to say, but when I do that, this is now going to be 0. I'm going to, because I'm going to get rid of that. I want to investigate what was the impact of changing from multiple micronutrients, changing from iron to multiple micronutrients. And so I say, okay, that's the test I want to run. And remember, in LiST, nothing else is going to change over that time period except population. So we still keep changes in if the number of births is increasing. We still do the demographics, but we don't make any assumptions about change in mortality. And I can apply it, and I say next. And then what I'm going to do is this, you always go, you can review default data. We're not going to do that right at this moment. And I'm going to say calculate and view results. And so now we're back to checking, to running to our server, and it's going to pull up our results. Now what happens is when you do results, it gives some standard results, but you can go and look at others. So that, you know, it's showing me child deaths, you see are still going up. So that means population is probably going up, death by cause. But one of the interesting thing is additional lives saved. So what additional lives saved means is it says how many lives are saved in this new thing of using multiple micronutrients versus the old. So what happens is it says, hey, a switch to multiple micronutrients saves about 200 children a year, over and above what iron supplementation would do. So you can say, hey, over a period of time, you're saving 200 or 300 kids. It's not a major, but it certainly suggests that it's better than iron. The other thing you could look at is you can go manage results and say, well, what are other things that it might have an impact on? And I am sitting here thinking about, so you see I have child deaths and deaths by cause. I could turn both of those off and say, I don't want to see those anymore. I want to do save by interventions. Does it have any effect on stillbirths prevented? Does it have any impact on birth outcomes? And I'll say, okay, let's look and see. And then what you see is it does save lives. It does no impact on stillbirths. It has a very small impact on overall mortality. And it does seem to have a little impact on some of the birth outcomes. So that what happens is you can quickly, the main takeaway here is that you're going to save more kids using multiple micronutrients than iron. So in fact, it suggests it's a more efficacious intervention. So let me go back now to, I want to create a new projection. And this will be my last little thing here. Actually, given the time, I'm going to, well, let me do one quick one. The other thing, another way you could answer a different question is in Mali, there's some, let's say, what's going to be the impact in Mali of if we could reach our SDG targets for stunting. What would be the impact in terms of under 5 mortality if we could do that? Just to show you quickly, I'm going to be really fast on this. I'm going to create a projection. And one of the reasons I wanted to show you this is in our risk factors, you can either choose to have the risk factors driven by changes in coverage of interventions, or you can also go back and do explicit, say, if I cut stunting by half, what would be the impact? So let me show you quickly what I'm going to do here is if I look at my interventions, and I'm going to go down here and look at nutritional status, and I'm going to turn on what's called direct entry of stunting. And I'll apply. So the MDGs are set in numbers of stunting cases, but in fact, what I'm going to change this single indicator. Basically, it cuts the rate by about not quite in half, but let's call it half. And so I'm going to make this say my target is be 15.5% from the current 31%. I'm going to assume that I get kind of a slight decline, and then we're going to stay at that level going across, that we've reached the target early. And I say, okay, so that's what I would like to test. So I'm saying, what would be the impact of reaching the MDD targets for stunting? What would be the impact on mortality? So if I go and say next, again, I don't want to do this. I want to view and calculate results. It's again going to do the computation. And it's going to say, so you can see what happens is that we get a fairly large number of lives saved over time because we've changed it. I can go back and say, let me look at what I really want to look at is I want to do under 5 mortality and neonatal mortality rate, okay? And it shows, yes, my under 5 mortality rate went from 94 to about 87. So it's about an 8% reduction in mortality by reaching their SDG targets. So let me just get out of here quickly. The idea behind LiST is that what we tried to do is make it easy for people to use and to try to make sure that accessibility to data is there, so that when you load the model, you get lots of information about coverage, mortality rates, levels of risk factors. All of that is modifiable. So if you're working in a country, you can change that yourself or add new information. If you have new, more recent information, you can do that. It also allows you, if you think the efficacy values that are defaulted in the model are incorrect, you can change those. We don't really promote that because we work pretty hard to get these Cochrane reviews and things to do that, but it allows you to do it. The model is updated on a regular basis. That generally, that's a big part of our work, is updating and putting new data information in it. Right now, we run the thing in, it's available in French and English. If that helps, especially in West Africa, that you can switch everything over to French. There are other languages sometimes, but we don't update Portuguese as much as we do French. And the other big thing is we're starting to develop more work with browser-based links to the models, so that you can, some organizations like UNICEF creating their own models that are built on top of LiST. So I'm going to stop at this point and let's go. I'm a little over time, but.
That's okay. Thanks, Neff. So we don't actually have any questions. Well, we had a question from Mark Myatt initially, where he was saying it would be helpful to see kind of how changes cascade through the model, which I think you explained verbally. And I think actually, just showing how to run a projection means I think folks could also play around a little bit with that. But now, and Mark says, yes, it looks nice. So thanks, we're glad. You know, while we're waiting, so please, those who are attending, please go ahead and put any questions that you might have in the Q&A. Then if I actually had a question, what if, you know, for example, there's a lot more evidence right now coming out about SQLNS, you know, and in my quick look while you were doing the visualizer, I didn't see, you know, small quantity lipid-based nutrient supplements in the model. If I'm really interested in that intervention, is there anything that LiST can kind of do for me, even if it's not there yet?
Yeah, there's two things you can do is that, you know, people, as you know, Rebecca, people are duking it out about is in fact small quantity lipids really better than our assumptions about kind of general complementary feeding. And that's still kind of an argument. But one of the things you could do is you could simply within LiST, if you say, well, that is, you know, more effective than the general provide more calorie-based supplementation, you can go and change the efficacy value and have a direct, so you say, well, there's been a recent Cochrane that says, you know, just the general complementary feeding reduce the risk of stunting by 30%, lipids is by 40%. You can go in and change the efficacy value within the model and then say, now I'm going to do it using two different efficacy values, which basically would be the small quantity lipids versus the normal complementary feeding. So that's one of the nice things about being able to go change those efficacy values. What we try to do in the model is make sure everything's transparent so that people can look at it and say, you know, I don't really believe that. I don't believe that WHO estimate, or I've seen a new review on efficacy of intervention. I want to try that. And the model allows you to make those changes and then see what the impact would be.
Great. Thanks, Neff. So we do have a question from a participant asking, Grace Aggie is asking, is it possible to use LiST to track nutrition financing and make projections about changes in nutrition finance and its impacts?
No. The short answer is no. So in LiST, we do, we haven't put it in LiST online yet, but on the LiST desktop, we do have a fairly big costing module. But we are not. So for us, what would happen if you were interested in financing and then what impact that would have, that you would have to do the work. We do not have that in the model of saying by this increase in financing, this is what would, this is how much additional funding would be. And then you would have to say with that funding, how would I spend it and how that would result in coverage changes of different interventions. We, in fact, Victoria's not on the call today, but another team member, we kind of did that work with GFF, where GFF was saying we're going to be able to leverage additional funding for overall child survival, not just nutrition. And then we had to work to say, okay, given that, what would that result in coverage changes of interventions? And so you kind of have to decide how you're send it, but the model doesn't do that. So we don't work from financing to coverage change.
Thanks, Neff. But I guess I would say, is there anything you could do about understanding how much it would cost to achieve?
Yeah. Yeah, that again, if you use the LiST desktop version, you can estimate cost of scaling up interventions. We use kind of the same ingredient space approach that WHO does in One Health. In fact, we use the same kind of underlying databases for assumptions about, you know, time of service provider and standard costs for supplies and equipment. So yes, we can within LiST, you can run it where you say, I do this, I've scaled up, let's do multiple micronutrients. I've scaled that up, it gives you a price, then you compute what's the kind of incremental cost of scaling up multiple micronutrients, and then you can go back and use that with benefits and kind of do a benefit cost analysis of scaling up multiple micronutrients. So for the example I just gave you, we also could compute cost and say, okay, now I have the ingredients I need for a BCA analysis about making the decision of switching from iron to multiple micronutrients and Benin.
Great, yeah. So we have a piece of the financing puzzle in terms of at least some help with costing, but like you said, that's only in the desktop version, not in the online version.
Yeah, we still got a little more work to get it online.
Yeah. So we have a question from Jennifer Yurkovich saying, can you use this tool to work backwards from a stunting projection to examine different intervention scenarios to get there? So you'd put in a stunting goal and then get a list of indicators with a sliding scale for gap values that lets you see different scenarios that would help you plan interventions.
Yeah, but yes, don't you love answers that start, yeah, but that what happens in LiST is we don't have some kind of optimizer or algorithm that allows you to say, set a target, and then what are the possible ways to get there. What would happen in LiST is that you would simply, what I would do if I was doing that, I would go and first look at the LiST visualizer and say, okay, what are the things that are linked to my target? And so if you're trying to cut stunting, and then say, which interventions are most effective in reducing stunting, which ones have low coverage now, and then go in and say, if I scale those up, and you could say, what my approach would be is take everything, scale it up and say, ooh, yes, I'm way over the target. So now I can go back and take out some of the more costly interventions. And that would allow you to kind of get a good way of doing it. But it doesn't, so it doesn't do that automatically. You would have to play with it. It actually doesn't take long, as you can see doing this. It'd be quite easy to say, like I say, my approach would be scale them all up to like 90% coverage and say, okay, that would do it. That gets me well beyond the goal I want. Now, which one of these would I, or easier to scale versus others? Because the model also doesn't capture how easy it is to scale up an intervention from 30% coverage to 90. Some we know require infrastructure, very expensive, or better health systems, where other things can, like bed nets is kind of the classic example. Countries are able to scale that up to 80, 90% coverage in a few years because it doesn't require the infrastructure to do it.
Great, thanks, Neff. So yes, the but is, it's not an automatic thing, but manually, depending on someone's kind of approach to using the tool, you could move towards that question. So
yeah, and just to follow up on that, you'd have to be good at it, but let me say Yvonne or Hannah or I could probably answer that question in a country in 5 or 6 minutes. It's not that, it wouldn't be that difficult to do to be able to manipulate that. If you really wanted to get into cost and things like that, it would take longer, but it's a fairly simple thing to do. And it's one of the reasons we haven't focused on creating these set targets, and then it does the computation for you.
Great. I'm going to throw in another question of my own, since we don't have any, but encourage people to continue to put into the Q&A because we do have a couple more minutes. So Neff, what if, let's just say theoretically, I worked a lot with LiST 2 years ago, or maybe 3 years ago, but haven't really been working with the tool as much recently. Clearly, there's now an online version, which is a huge step forward. But are there any other either changes or updates to the model that me, especially as a nutrition person, might be interested in recognizing that's maybe have happened over the last couple of years?
You know, that this is a little embarrassing because the reason we picked April 15th, we were supposed to have our 2 bigger changes. So there's been several changes from a couple of years ago on efficacy values. So we've done some reanalysis for some of the efficacy and the risk relationships that have changed in the model. And most of that, when LiST originally started, we had an expert group. This was worked with WHO and UNICEF. That kind of died out. Now, most of the times, the reviews are driven by requests from Gates, who funds a lot of the LiST development, or by working with Lancet series on nutrition. So they've really driven much of the changes within the model. And as you know, a couple of years ago, both SIF funded a kind of complete review of all the assumptions in LiST related to nutrition, that you worked on big chunks of that and led it, and we made the changes. There's also some other things that we're just now, they're not in the model yet, but one of the changes is that we are now adding to LiST and LiST Online long-term outputs of changes in stunting in terms of both lifetime earnings gained by reduction in stunting and changes in years of schooling based on reduction in stunting. And that's all based on, there's several people that have done work on that, looking at studies over time. So that now is something the model is, we're in the final stages. Hannah has been doing that work and we're just about ready to drop it into the model. Other things we've done is look at trying to produce estimates of coverage of SAM and MAM. One of the difficulties in the model, since we need baseline coverage, is that we don't have estimates of coverage of SAM and MAM. What we have estimates of is service provision. And then we have to correct that for incidence and also measurement error, because if they use, anthropometry, kind of the standard height for and weight as opposed to MUAC, you get different values. So we are trying to, that is also, again, Hannah working on that is going to be added into the model. So there's a couple of new things. Generally, I would say if it's been 2 years, there's going to be changes, except for areas in nutrition, there's always going to be changes. It just seems to continue to get a better understanding of what's happening. Like, for example, the idea of calcium supplementation and what the impact is, that we have more information now and more assumptions about the effectiveness of that on birth outcomes.
Thanks, Neff. Yeah, I mean, I think that to me is one of the biggest things about LiST that I think is such value, is that it does continue to get updated over time, that even if people can't see, well, clearly the interface jump now online is a big one, but that there are things are changing. And so I guess I would say, I think the answer is knowing that you are pretty open for people to reach out if they're trying to understand, or trying to understand how things have changed, to you and your team to really get a sense of that, right?
Yeah, absolutely. And what we do is about every 2 years, and we're just now doing another one, we publish supplements and journals that kind of document all the where things came from, where assumptions changes and how they were made. So we did one specifically in 2017 on nutrition that had about 10 or 12 articles in it about all of the updated assumptions at that point, and we're currently trying to do that now. We've got about half our papers submitted and it'll be out this summer. But we also add everything again when you're either on the visualizer or in the model. In most cases, if you highlight a cell, you can right click it and it'll show you where that information came from, what it's based on, whether it's coverage value, what DHS or mixed survey it came from. And if it's an efficacy value, it gives you a link to the article that we use to estimate efficacy. And you may look and say, "Ooh, they need to update that. There's a new," somebody did that to us the other day. They said, "Oh, there's a Cochrane that came out last week. Your estimate of, I think it was calcium, is incorrect. There's a new meta-analysis." So it takes us, we didn't see that. And so now we've got to change that in the model.
Great. Yeah. And those, I'm excited about the human capital impact piece, because I know that's a big piece for nutrition. So,
yep.
Some good things yet to come. So many good changes and some good things yet to come. All right. Well, I actually don't see any more questions at this moment, but again, want to thank you, Neff, so much for you and also your team members who we know are behind you on this. And also want to thank all the participants for joining our webinar today. We hope you enjoyed it. Want to remind you that the recording of the webinar is actually available immediately on the Data for Nutrition YouTube channel. Copies of the presentations and a summary of the Q&A will be shared on our Data for Nutrition webinars group page in the coming weeks. But do encourage you to go ahead and let others who might be interested in the LiveSave tool know that this is one place they can go to learn some more. Thank you, everyone.
Can I just add one last thing? I would encourage people, please go to our website. If you are interested, we have lots of videos and training applications and things available in French and English that can help you, I think, and myself and Hannah, and you can always contact us via email if you have questions, and we'll be happy to help.
And that's just www.livesavetool.org, right?
Yes.
Great. And we'll definitely have, so we have the link in the chat, and then we'll also, when you go to the Data for Nutrition website, all the follow-up will definitely make that clear to everyone. So anyway, thank you so much, Neff. I'm excited to see how LiST keeps advancing.
Okay, thank you.
All right, goodbye, everyone.